Today we are continuing the concept learning series of based on navigation assisted TKRs, or you call it as a robotics, okay, or computer assisted. It's all one and the same. Robot is just one arm extra to the navigation. Okay, so we are starting with this series with the virus knee. Okay, so taken as a part one because we can cover it. It's a very huge topic, so we'll be covering in probably in two parts or three parts. Okay, so as we all know that varus knee is the most common. Most of our clinical practice we see about this varus knees. Okay, so sometimes we do sagittal plane deformities. The sagittal plane deformities includes FFD or recurvatum deformity or hyperextension, whatever it called, hyperextension or recurvatum deformity. Most of the times, most of the times when you see knee with varus, okay, the knee is varus, this is the midline, there will be an associated sagittal plane deformity. Okay, there will be an associated sagittal plane deformity. That is what, when the varus knee deformities continues or it progresses, it leads to a biplanar deformity. Biplane is what? Varus deformities in the coronal plane, and the FFD or the hyper extension deformity comes in the sagittal plane. So it always becomes a biplanar deformity, and it progresses and it lead to triple deformity as well. Okay, that we have read in the tuberculosis as well. So most, even though osteoarthritis, the varus knees, if there's a severe varus, they're always associated with FFD or recurvatum deformity. Okay, so we all know the soft tissue release sequences for any varus knees is: first we take out the osteophytes, then we release the deep MCL from the medial side, from this part, then we go release the posteromedial part of the capsule. Okay, even then if it is not released, then we start releasing the submembranous insertion. Then even then it is not possible, then we do reduction osteotomies, right? Even then the varus, if the medial side is tight, we go for pie crusting of the MCL, that is superficial MCL. And at last, if all these things are not, then we can go for a medial epicondylar osteotomy. Okay, these are all the ways where, and a sequence of events which we do in the soft tissue release. The question is, if I release this, for example, if I have gone for only 1 and 2, okay, if I have gone for 1 and 2, how much correction do I get without the use of navigation? How will I assess? It's just an eyeballing. I'm not sure, right? How will I get? So that becomes a little problematic, right? If I go for, should I go for one more step or not? Whether my virus is completely corrected or not, it becomes very difficult, right? So to assess that what is actually happening intraoperatively, this navigation helps. So before moving on to this varus knee, just few things about what varus knees are basically. We know varus knees, there's a coronal plane deformity, and most of the times it is associated with FFD. Literature says up to 85% of the cases. Some amount of flexion deformity will be there, and it will be amounts to always fixed flexion deformity. Okay, some amount of fixed flexion deformity will be there. Rest 15% of the cases will be normal or hyperextension. Most probably hyperextension. 85% of the varus knees will have FFD. Based on this combination, FFD and varus, we can further classify as three types of knees. When varus is equal to FFD, when varus is less than FFD, when varus is more than FFD. Okay, same thing can be there. Varus is equal to hyperextension or recurrent deformity. Varus is less than hyperextension deformity. Varus is more than hyperextension deformity. These things usually we see in a neuropathic joint. Okay, neuropathic joint, and most of the times it's a straightforward. If there is a sagittal plane deformity, we we need to think of hinge knee. Okay, we need to think of hinge knee, something of that sort. Okay, so but in our clinical practice, this is the three major scenarios which we encounter. Okay, so with this background, how can you plan for varus knee with FFD? What are the things you do when you are doing for a varus knee FFD? Before moving taking out this question, what could be the cause of this deformity? That means what? We have a varus. Why this varus always, that means 85% of the times will go for FFD? Why this thing happens? Any guesses? Muscle contraction? Yeah, very good. What muscle contraction? You have to go for FFD, right? One is because of the pain. Okay. Because of the pain, the patient tends to keep his knee in flexion, right? The patient gets to keep the knee in flexion. Muscle contraction can happen, but muscle is a dynamic structure. It can stretch out. The most important thing what is happening is your posteromedial structures, especially your capsule is the one that is getting contracted. And this progressive deformity will cause a excessive pressure on this part, posterior medial part of the tibia, this part, and there will be loss of bone. Excessive rubbing will happen and will lead to loss of bone. This is how basically your varus knees keep on start uh, progressing towards a biplane deformity and leading to have an FFD. Okay, consider this case. Okay, you have a case here. For example, as we all been taught in the PGs that whenever they have an FFD of more than 10 degree, you cannot call whether it's a varus or valgus. Okay, that's a basic teaching for the post graduation. Okay, this is little one step higher. We do have a biplanar deformity called as varus deformity with FFD. Okay, we do have, but that quantification is required with the use of navigation only. But with the plain eyes, for a PG exam point of view, anything deformity of more than 10 to 15 degrees FFD. Okay, if the FFD is more than 15 degrees, you cannot call it as a varus or valgus. Okay, you cannot quantify it. But for orthoplasty surgeon, we still can get it. I'll show you how the use of navigation comes in. Okay, so consider this for example, this has got an FFD of 10 degree and varus of 10 degree.